Assalamu alaikum. Bismillahirrahmanirrahim. It's almost painful to stop listening to Muhammad Rana Saab, and but unfortunately we have to come back to the madhouse. And I was very willing to give you my time so we could hear more, but there's nothing here which most of us do not know. So we're going to talk about the role of beta blockers in primary prevention of coronary heart disease. The topic has actually been changed, which has not been changed here. And that is the role of beta blockers beyond the control of hypertension. So a lot of things have been covered so far, so I'll just frisk through them. So, it's a chronic condition which has effect on different organs, and of course, the definitions of heart failure, of hypertension, and we know that it's a leading cause of morbidity and mortality across the world. There is a proper way of checking the blood pressure. I'm just like reminding you of these things so that we can get to the point, which is the role of beta blockers beyond the control of hypertension. And of course, we, as anything else in life, nobody agrees. So the AHA and JNC7 and all the different societies, they have different criterias, but we all understand that 140, 90 beyond should be controlled, and before that's pre-hypertension, that's the JNC7. And then, when you're exposed to high blood pressure, you expose yourself to the infarction, heart failure, stroke, renal failure, and premature morbidity. Let me just go through them. And the reason why some of them are not controlled well are because of various factors which happen. Some are physician-related, some are patient-related, environment-related, so on and so forth. And even when somebody detects blood pressure, many physicians fail to respond appropriately. So these are the effects which happen when you're controlling, with hypertension. It could cause stroke, vision loss, heart attack, kidney, heart failure, and erectile dysfunction. And there's some percentages related to it, which is quite significant. And our data should be here, but this reflects the Indian. About a fifth of the population has hypertension. And amongst those fifth, a third are diagnosed, and the rest are not. And a third are treated. And so despite inadequate diagnosis, the will of the people and the patient results that half the patients remain totally uncontrolled. So we know about the diet involved in controlling blood pressure, and the calorie intake is important, the salt intake is important. And then we have got these different guidelines, and the guidelines state that how ACE and ARBs are good starting points, and for different races, maybe the calcium antagonist and thiazides are good. And if they do not combine, or you cannot tolerate ACE, then you go to an ARB. But if things are not controlled in step 2, you start adding them together, and you can add on till 3 drug. And for those people have advised poly pills. I'm just rushing through them so that we can get to the real crunch of the whole thing. And so let me just read some of these to you. And so as you would see that at this point, we have still not touched beta blockers, because as we'll show that beta blocker on their own tend not to be good at the hypertensive, which may be contrary to some of our own experiences. So this is the lifestyle. So for people, you got to start with lifestyle modification. You add on, and so we started off with controlling blood pressure for different races. When you give these drugs and you start on with different, you find out that it's not just the blood pressure which needs to be controlled. You need to take it in relation to what other illnesses the patient has, diabetes, and so on and so forth. So the best choice of drug would change based on your age, diabetes, and your kidney disease. And so as you continue with your drug therapy, you find that after all these combinations have been used, you will continue and lifestyle modification, adjusting different drugs. And in the initial workup, the beta blockers do not come into play. And it is at this stage when you reach a resistant sort of a position where you find that your basic drugs have not controlled, that you start adding beta blockers. That's the guidelines which say. And if you need to add a beta blocker, You probably need to add it for its other associations, like other association for beta blocker would be heart failure, angina, post-micro infarction, atrial fibrillation. Younger women, especially those who are pregnant and planning to get pregnant, they need to have a beta blocker. So talk about the benefits of controlling blood pressure. We can reduce the stroke, coronary artery disease, death by cardiovascular disease, and all-cause mortality significantly drop as the blood pressure is controlled, and that's a very important home take message. Now we talk about some aspects which have not been discussed a lot, and that is the heart rate and blood pressure variability. And the more variable it is, the worse it gets for you, and that affects your fitness, endurance, stress and recovery, and your overall cardiac health. And this heart rate and blood pressure variability affects the hemodynamic stresses which occur on the blood pressure, and that in response affects the arterial stiffness. And that stiffness again affects the variability, and so the cycle starts. And for that, we need to talk about the baroreflexive sensitivity and hypertension. And so baroreflex is the most important nervous regulatory mechanism of blood pressure. And high blood pressure leads to remodeling of the carotid artery wall, and its stiffness increases. And this stiff coronary sinus is less distensible during blood pressure increase, and the baroreceptor response by distension of carotid wall are thereby less activated. So normotensive and borderline hypertension subjects to the family history of hypertension exhibit a decrease in baroreceptor sensitivity compared with normotensive without a family history. So baroreceptor sensitivity tends to be a very important part in all your hypertension and its follow-up and its downsides. And baroreceptor sensitivity tends to be an independent predictor of a bad outcome in essential hypertension. The real benchmark of monitoring and outcome prediction is the central aortic pressure, while we check the brachial artery, which is a pretty close reflection of the central artery blood pressure. And for that, we need a good endothelial function. So if you have a bad endothelial function, your arteries will not relax. And if you are in good state, of course, there are different ways of improving the endothelial function, like diet, exercise, and so on and so forth, which we'll talk about later. So good endothelial function will improve vasodilation and help your blood pressure regulation. And if you do not have a good endothelial function, you're not going to have good vasodilation through a very complex mechanism, which includes nitrous oxide and so on and so forth. Hypertension requires a very complex approach, as we all understand, and everything we know about cardiology and medicine. And Professor Murree just made it more complex by asking us to zoom out, not just go on numbers, which is very relevant, of course. So the reduced baroreflective sensitivity is associated with increased vascular calcification and arterial stiffness, and low sensitivity is the independent predictor of risk factor for essential hypertension, like I just said earlier. So central systolic blood pressure is an important factor determining cardiac function, and while the central blood pressure may determine coronary flow, increased clinical evidence suggests that central arterial pressure predicts cardiovascular events also. So flow-mediated vasodilation, FMD, is diminished in patients with atherosclerosis. And bisoprolol has been an effective in addressing all these challenges beyond the usual blood pressure control. So this is just a reflection of how bisoprolol may affect the specific effect on arterial stiffness, and there's been a randomized trial suggesting that bisoprolol was more effective than other hypertensives in improving the arterial stiffness. This is how bisoprolol, along with improving vasoelastic property of the have been found to decrease arterial pulse wave velocity and decrease arterial compliance in hypertensive patient. This is in addition to comparison with atenolol, where atenolol does not improve vascular compliance and is relatively ineffective in lowering central aortic blood pressure. And so we continue with this evaluation and found that the systolic vascular resistance by treatment with bisoprolol is effective, more effective than some other drugs, including some beta blockers. And so flow-mediated vasodilation, bisoprolol, in patients with symptomatic coronary disease have benefit from improvement of endothelial function. So for patients who have coronary artery disease, beta blocker have a much more important role to play than in simple patients who have just essential hypertension without coronary artery disease. So bisoprolol was proved to increase survival rate in high doses. Increase of endothelial function in hypertension and stable angina with bisoprolol treatment was significantly higher than that without bisoprolol treatment. And a significant improvement of myocardial perfusion defect was observed in bisoprolol group. With bisoprolol therapy, the percent change was significantly higher in hypertensive patients with stable angina. So the moment coronary artery disease comes in, you got to pitch in bisoprolol, and we'll show that how different beta blockers are not the same, and they tend to, although they've been studied very extensively, but I think that's what progress is all about. That you start comparing even different apples to each other and find that all of them are not the same. This is a very complex diagram, cartoon, and it shows that in patients who have stable angina, the effect of bisoprolol is much more significant on the MPI scan than compared to people who don't have coronary artery disease. So for patients with coronary disease, bisoprolol tends to have a very important role to play. And this is now we're talking about the beta-1 selectivity of different drugs, and you can see that carvedilol and inderol, propranolol, are very relatively non-selective. It's all relative term because as you push on the dose, the selectivity tends to be overcome. And metoprolol and telol are somewhere in the middle, and bisoprolol is really up there. And when you compare it with nebivolol, you find that the selectivity in humans in bisoprolol in human myocardium is very high. Now that's a very important thing to play, that although bisoprolol may be more selective, but its effect on human myocardium compared to other viscera are much more. And bisoprolol compared with nebivolol showed that bisoprolol had a significant increased concentration of testosterone and prolactin, and lowering level of estradiol and FSH, and improved vascular blood flow in penile arteries, and did not worsen sexual function. Now that's something which people have really been tabooed against, that beta blockers tend to have a bad effect on your social life and sex life. And they're more pronounced in hypertensive effect of bisoprolol than that of nebivolol. So central aortic pressure is superior to brachial pressure in predicting cardiovascular event and chronic disease. Atenolol is significantly less effective for lowering the central aortic blood pressure and pulse pressure. And bisoprolol has shown to effectively reduce central aortic pressure, and this effect was directly proportional to the reduction of the systolic pressure of a similar magnitude. You can see that bisoprolol tends to have very minimal effect on the peripheral vessels. It has significantly more effect on the smokers. Yeah, last few slides, please. And in fact, in middle-aged people, it tends to be very effective drug to use as you compare to the older population. And it has less effect on the peripheral, on the airway resistance, and it had less effect on dropping the HDL. Bisoprolol had minimal effect on male sexuality. In fact, as you can see, it had the least effect when compared to other drugs, the usual drugs like amlodipine. And so in conclusion, it's now evident that bisoprolol has a significant role in improving all the metabolic parameters, addressing sympathetic overdrive, improving heart rate, blood pressure variability, pulse pressure, central aortic pressure, and flow-mediated vasodilatation. And all these parameters are beyond its role of blood pressure control. It is therefore seen reducing the risk of myocardial infarction, cardiac and all-cause mortality, improvement in heart failure, and sudden cardiac death. Hence, a logic choice to control essential hypertension and improving overall survival. Thank you very much.